Hello and welcome to our Grand Round series. Our Greenberg bladder cancer team is grateful you're here. Of course, seeing you in person would be preferable, but these virtual platforms have proven to be very effective for sharing information, for education, and most importantly, for discussion. First, a couple of updates. If you are new to being here, welcome. Please find our archive program of sessions from the last several years on our website. There are over 20 sessions available to view. For updated information about the Institute, be sure to simply Google Greenberg Bladder Cancer Institute. Further, I wanted to once again draw your attention to our evolving group of programs specifically tailored around the experiences of women with bladder cancer, developed and led by our team of Drs. Armin Smith, Jeannie Hoffman-Sensis, and the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper-Greenberg. Their programming details are also available on our website. And of course, please never hesitate to reach out. We will send you the details directly. Again, all of this information and more is up on our website. And if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. I'm incredibly grateful to all of you for joining us today for our session on cognitive functioning with cancer infusion therapies, often referred to by the public as Chemobrain. I'm very grateful to Dr. Tracy Vannorsdall for joining us today. If you would let me, I'd like to formally introduce Tracy. She is a clinical neuropsychologist and associate professor within the Department of Psychiatry and Behavioral Sciences and the Department of Neurology at Johns Hopkins University School of Medicine. She completed her doctoral degree in psychology at the University of Maryland, Baltimore County in 2006, following a one-year internship in clinical neuropsychology at the Ann Arbor VA Medical Center. Dr. Vannorsdall then completed a 3-year clinical and research fellowship at the Johns Hopkins Department of Psychiatry and Behavioral Sciences. She joined the faculty in 2009 and is currently an associate professor and the Director of Clinical Training in the Division of Medical Psychology. Her work with patients provides insight and motivation for her research, which focuses on developing methods to improve cognitive functioning in those at risk for neuropsychological declines due to illness and medical treatments. Tracy has agreed to share some thoughts with you, and then after about 30 minutes, we'll come back together for a chat. I would ask for folks to please submit their questions via the chat feature, and after the conversation, we will have ample time for group discussion. Tracy?
Well, thank you so much for having me. I'm going to see if we can share my slides here. There we go. So again, thank you so much for having me. I'm really happy to be here. I'm a clinical neuropsychologist, and most folks don't know what that means. I am a clinical psychologist, but I don't do psychotherapy. My work really focuses on understanding the way that medical illnesses and their treatments impact brain functioning in terms of our thinking skills, as well as our mood and behavior. And so today I'm going to speak about how cancer and its treatment might affect our thinking skills and how that evolves over time in the course of cancer survivorship. We'll talk about what types of thinking skills are affected, and then, the majority of my talk will be pointers on how to best manage these cognitive issues. And the first point to note is that, this is a bothersome issue for patients. There we go. So these are data from about 4.5 years after cancer diagnosis for a range of different forms of disease. And what you see is that if patients are asked, do you think that your thinking skills, your memory and attention and the like, are as good as your same age friends and neighbors? We see that nearly half of patients across a range of different disease types will say that, no, I don't feel like I'm quite as good as I should be, given my age and background. And that tends to persist over time, that sense of something being slightly off. And so we've all heard the term chemobrain. When I talk with patients, what they often tell me is that they're having difficulty coming up with the words that they want to use. They are a bit more forgetful. They have difficulty multitasking and bouncing back and forth between tasks without sort of becoming eventually distracted away from one of the things that they're doing. It's efficient. They're noticing that they're making more errors than they used to before their illness and treatment. And so we call it cancer-related cognitive impairment or cancer-related cognitive change, because in fact, there are a number of different contributors to this type of change in our thinking skills. There certainly is the chemotherapy. We know that patients who have higher dose chemotherapy and those who have chemotherapies for longer durations tend to have more cognitive difficulties. Now, of course, if you need higher doses and you need a longer round of treatment, you also may have a more aggressive disease. And so it isn't really comparing apples to apples in that way. And there are different combinations of agents used over different periods of time. There's the cancer itself, which we're increasingly appreciating has its own impact on brain health. Surgeries can put in general anesthesia can put folks at risk for transient disruptions in their thinking skills, as well as episodes of delirium. So patients can get really confused after their surgeries in some cases. Radiation, depending on where that is administered to. Many of our patients are also on a number of other medications like steroids, pain medications. For some folks who have brain metastases, they may have anti-seizure medications. All of those affect our brain health. And then for some folks who have surgery or medically induced menopause or androgen deprivation, there are those hormonal changes that we know are important for brain function. All this is happening against a background of a lot of stress, particularly early in the disease course when you're figuring out what the plan is and really getting things into action. And so patients can develop problems with mood and anxiety. There can be PTSD-related symptoms, when folks are faced with a serious medical condition. And there are other issues like sleep, pain, and fatigue that all combine to affect our brain health and our thinking skills. So for that reason, we've moved away from the term, chemobrain or chemofog, and really are calling it this cancer-associated cognitive impairment. And while it can be intimidating to see, there sure are a lot of things that can negatively affect my brain health, I tend to look at it in a different way. I think that it's a bit more empowering because while there are some things that we don't have much control over, like having had cancer and which treatment regimens our providers think are most appropriate for us, there are many things that we can address. We can address our other health conditions that might be affecting our brain health. Certainly our health behaviors like our sleep and activity and nutrition. We can be looking out for medications that maybe before cancer weren't really triggering much in the way of cognitive difficulties, but now are, possibly contributing. And so we have a lot of this sort of low-hanging fruit where we know that we can make interventions and try to turn things around, which I think is quite empowering. So I use the term cognition, but that really means thinking skills. It's our ability to learn from the world around us and use our resources to solve problems. We generally think of these as multiple different domains of cognition. Patients almost always talk about memory. That's the major term that we tend to think about, our attention and our memory. But there are a lot of different ways that our brain processes information. It's our thinking speed. It's our ability to pay attention, to stay focused, and then to selectively deviate our attention to other tasks and circle back around. Our ability to learn new information and to hold on to it, of course. And then things like our ability to understand language and communication. We typically don't see those issues outside of sort of brain tumors, but word finding, our expression can be a really common area of difficulty for patients as we age, as well as in the face of cancer-related treatments and a number of other health conditions. It's word finding pauses are really ubiquitous. And then planning, problem solving, and spatial skills. So when we talk about thinking, we really need to be thinking about which particular type of thinking skill might be affected. And we know that cancer and its treatment can affect different brain regions that underlie these different skills, as well as the pathways that help those brain regions talk to one another. So it's a complicated system, as you might imagine. And one of the causes of cognitive changes we really think is that biology of cancer itself, that it is in many ways an inflammatory process. And when we have systemic or body-wide inflammation, that tends to affect our brain functioning as well. The chemotherapy, while most chemotherapies don't cross the blood-brain barrier, and it can make that barrier a bit tighter. So those toxic agents may get in a bit quicker or more easily in the case of cancer treatment. And we think that it's particularly bad for these what are called neural progenitor cells, which you all don't need to know or remember, but these are important areas of the brain for our memory functioning. And so we have, good sort of basic science telling us that there are some real reasons why cancer and chemotherapy might be bad for our brain and result in changes in the size of different brain structures, the way those brain structures talk to each other over time. And we can see a trajectory over the course of cancer diagnosis, treatment, and recovery in terms of how those brain areas change in terms of their functioning. Right. And in terms of that timeline, what we see is that, across a range of different types of cancer, you'll notice that bladder cancer is not on this list, and I'll go over the literature on that's specific to bladder cancer here in a moment. But again, across a number of different types of cancer, we see that before you start systemic chemotherapy or anything that we would think would affect brain function in particular, that there can be really high rates of baseline post-diagnosis, but before treatment, cognitive difficulties, right? Patients tend to have slower thinking speed and poor attention. And we think that some of that is because of the inflammatory nature of the cancer itself. During treatment, particularly during chemotherapeutic treatments, about 2/3 of patients will really feel like they're off their game in terms of their cognition. And once chemotherapy gets on board, we tend to see more difficulties with things like memory. And that's because we think it's because of the way that chemotherapy in particular affects the brain. Thankfully, as we move further into survivorship, we tend to see these cognitive skills rebound. Most people will tend to experience a sort of steady improvement in their thinking over the first year or two after their treatment ends. We do see from large epidemiologic studies that maybe around 15% of patients will have subtle, persistent cognitive difficulties in the areas of thinking speed, memory, word finding, those types of issues. But typically, in our patients who don't have brain metastases or brain tumors, these are bothersome, but pretty mild deficits on cognitive testing. And they're issues that we can help patients work around. Now, when it comes to bladder cancer in particular, there have not been very many studies of objective tested cognitive functioning in this patient population. It's really an area where research is lacking, unfortunately. We have a couple of studies regarding patients who are scheduled for neobladder establishment, because these patients need to have the cognitive abilities to handle their neobladder correctly, to appreciate when something is malfunctioning, when they need to alert their treatment team, they need to be able to follow their treatment regimen, and having a cancer and going through treatments that requires a lot of cognitive skill and ability. There's a lot to manage. So this first study came out in 2016. It's from a Swiss group, and they looked at how thinking skills before surgery was associated with changes in thinking skills after surgery. So they tested people before surgery, 90 days after, 6 months after, and a year after. And what they found is that those who had poor thinking skills before they, as they're going into their treatment, before they had that surgery, those who were already weaker tended to have a dip after their surgery at about 6 months. Their cognition declined, but it returned to their baseline or close to their baseline by a year out. So we tend to think that those folks who are already having a bit of cognitive difficulties early may be a bit more subject to the stressors of having a surgery, and that may contribute to some cognitive difficulties that's pretty transient. But thankfully, having lower cognition during that dip wasn't associated with any surgical complications or the progression of cancer over time. It was really a transient issue. The second study came out just last year from a group in Germany, and they looked at a bunch of different tools to help measure cognitive difficulties in patients with bladder cancer. And they decided that this one here in panel A, the DEMTECT, is the best one that they wanted to use. And what they found is that before surgery, 27% of patients already had some cognitive difficulties. Now, some bladder cancer patients tend to be a bit older on average, and so there's the cancer-related issues, but it's also the case that patients may be aging and may be more at risk for other reasons to have cognitive difficulties. Some may have had some mild strokes or other vascular injuries, or be early in the course of other diseases that affect brain functioning. So just over a quarter of patients had cognitive difficulties, and of those folks who did go on to surgery, they did have more complications. And so it's something that providers and patients sort of want to keep an eye out for, because it may mean that we want to be monitoring those patients a bit more closely. Additionally, about a fifth of patients had at least mild to severe symptoms of depression, and about 30% had mild to severe symptoms of anxiety. And this is pretty common across many different types of cancers. Early in the diagnosis and treatment phase, we see a real spike in symptoms. Mental health symptoms. And the important point is that these are addressable. Typically, they'll sort of peter off and they'll improve over time as folks get into their treatment. But for some folks, they do tend to persist. Now, it's also the case that our self-reported cognitive difficulties, that sense that, you know what, I'm really off my game, I'm making mistakes, I don't feel quite right, that those complaints and concerns tend to really be very strongly linked with how your mood is and your anxiety, as well as how tired you are. It's a stronger relationship with mood and fatigue than even your performance on these sort of more objective paper and pencil cognitive tests. Now, it may be that our tests are just not sensitive enough to detect what patients are experiencing, but in either case, the data suggests that it's, that these issues, mood and fatigue, might be a way, might be something that we can target to help improve cognitive functioning in everyday life, right? And it's the case, I'm in a department of psychiatry, that's my home base, and we know that depression, anxiety, and fatigue undermine our thinking skills. You can take a group of patients who have never had cancer, and if they have depression, anxiety, or chronic fatigue, you often see that their thinking skills are a bit lower than where we would normally expect them to be. And so in the context of cancer-related treatments, it may be that our mood symptoms are underappreciated, they're underdiagnosed, they're undertreated. And there's sort of a notion that while you're going through a lot, being distressed is normal. And while that is the case, that doesn't mean that we shouldn't be treating it and addressing it, because it can help with your cognitive functioning to help improve your mood and reduce your worry and help your level of energy. And it, obviously is something that affects your quality of life as well. So in terms of improving those issues, there's nice data to show that physical activity, getting good nutrition can be helpful. Engaging in support, getting adequate social support. And sometimes folks get that from their family and friends, but other times they find that support groups are really useful for helping them adjust, helping them learn about their condition, and help them manage their expectations as they're going through a stressful time. It tends not to be, support groups tend not to be quite enough if somebody's experiencing what we think of as clinical depression and anxiety. And that really means that those symptoms of anxiety, worry, low mood, not enjoying life, that they're keeping you from functioning in your normal way. And so if they're at that level, that they're keeping you from, doing the things that you normally want to do, that's certainly a time when you need to talk to your provider about these and really advocate and make sure that we're getting you the treatment that you need. And that, from a professional perspective, can be psychotherapy and supportive counseling. This is not simply sort of sharing your anxieties and fears. There are very specific forms of treatment that have really good, scientific data behind them to show that it improves patient functioning and mood. And then, of course, there are antidepressants that patients sometimes find quite useful either on their own or in conjunction with these other interventions. Fatigue and sleep disturbance is also really common and can make you feel miserable. All of us have had periods of time where we've been sleep deprived, and you're not thinking your best. You're not emotionally steady as you normally would. It takes you longer to complete tasks, and you make more errors. So we want to try to address that. And cancer-related fatigue is its own sort of entity. It's a condition in which you're having this distressing, really persistent lack of energy. And it doesn't really matter, it isn't like normal fatigue where if you go out and you really exercise a lot, you feel more fatigued. Your activity level and your fatigue level aren't tethered together and correlated in the way that we would normally expect. You can't just have a good, long, restful weekend and sleep it off, and it interferes with functioning. And so this is a real entity, and we know that there are some things that we can do to help address that. One of which is exercise. We know that exercise, as well as psychological interventions, alone or in combination, are effective in reducing that cancer-related fatigue. It works during treatment as well as after treatment, which is nice. The type of exercise actually, or physical activity, doesn't tend to matter. It can be things that are as gentle as Qigong and chair yoga, or more vigorous exercise if somebody's up to that. And in terms of the psychological interventions, cognitive behavioral therapy has been found to be particularly effective, and both of them work better than medications for fatigue. So better than taking a sleeping pill is, taking some of these other approaches. Now, in terms of cognition itself, one of the things that we often focus on is using compensatory strategies. And that really means use your areas of strength to compensate or create workarounds for your areas of cognitive weakness. And you realize you may have to do things a bit differently. You've got to sort of make some new habits. And it takes some time to work at that. And then there's also cognitive rehabilitation, which is typically administered by our speech language pathologists that help you better integrate these compensatory strategies into your everyday life. You practice them with this the speech and language pathologist until you really got it down and you're effectively using them in your everyday life. And so quite often, one of the first steps is to start gathering data, to keep a log or a diary that'll help you find patterns of what types of cognitive errors you're making, what times of day you tend to make them. Are there certain circumstances, like when you're in a really hectic environment, when you're up against a deadline, when it's a really complex task? And are they occurring more often when you're fatigued or really stressed or feeling quite anxious, right? And once we get a good sense of what types of problems you're having, we can sort of create our workarounds and be more strategic and know when our vulnerable times are. So particular strategies, I like to tell patients that our learning and our memory are like a file drawer. So patients will often say that they're having difficulty remembering something. But when I really get down deep with them and talk about what's going on and what we're noticing in those logs, is that they're not actually paying attention. They're not in the moment, really attending to what's going on around them. They might be sort of going through the motions. They may be having that internal dialogue with themselves, but they're not right there, sort of in the moment and attending to what's going on. And if you don't attend to what's going on, you're not opening that file drawer so that information can get in. And if it's not in there, you can open that drawer back up and you're never going to be able to pull it back out. You're not going to have that memory of the information. So you need to pay attention so that it gets in. And then to be able to remember it better, to pull it back up, we want to make it a rich memory. We want to link it to other relevant information, right? And so we want deep learning. You need to be thinking about, are you actively listening? In talks and lectures and when in work meetings, I encourage people to rephrase information or take notes in your own words. The actual nobody writes anymore, but the data show that writing things down, physically writing longhand, organizing it on a page actually helps things sink in better than typing it or dictating it. And you want to be making as many connections as possible. So thinking about new information in as many senses as you can. You're looking at the person who's talking to you. You're thinking about what questions you might ask. You're taking notes. And then you're also gently reminding yourself or questioning yourself, am I still paying attention? Have I gone off and my mind's wandering? Okay, bring it back together. And that's a habit in and of itself that folks can develop, sort of checking in with yourself and pulling your attention back to the task at hand gently. We don't want you beating yourself up. Treat yourself with some grace. We also know that repetition is really helpful for improving our memory for particular information. Our brain sort of uses these well-worn paths, and the more we think about a topic or an idea or a particular event or list of things we want to remember, the stronger that pathway and the easier it is to pull information back up from memory. So repeating information. I've got 5 things I'm getting from Target. They are, I'm going through the list. And next time you remember that you're headed to Target at the end of the day, pull up that list mentally again and go over it. And that's going to strengthen that so that you're less likely to walk out of the store and get home and realize that you've forgotten what you intended to buy. And on the other side of reminding yourself is giving your memory a bit of a rest, using technology to your advantage. I encourage folks to take notes, make checklists. For some of my really bright patients, they say, well, I've never had to do that before. I don't want to have to do it now. For the time being, let's do what's available to us. And hopefully through the course of recovery, you won't need to anymore. But as we age, it's a pretty normal part of the aging process that we start noticing that we need to rely on these external aids like reminders and alarms. The big key thing is making this something that you can do consistently so that it becomes a habit. It's part of your life. It's not Post-it notes all over the place. It really needs to be something that is organized and something that you can keep up with. So that may be something as simple as an index card in your front shirt pocket, if you're somebody who has a front shirt pocket, or using smartphone apps, things like Evernote or To-Do or the Google tools that can all sync across all of your devices. There really is a lot out there that can be used, and our speech language pathology group in particular is great at helping people integrate those into their daily life, depending on what platforms you feel most comfortable with. It's also the case that our memories become consolidated or made more firm during our sleep. So it's another reason to get good sleep because it helps our memory. But it's also the case that if you review things at the end of the day, assuming that they don't make you anxious or sort of rile you up, but in the evenings, thinking back over the important events of the day, anything that you're wanting to make sure that you remember, it can be helpful to do so because then that process of sleep helps consolidate or make those memories more firm, and you're able to pull that information up much more easily the following day. Word finding, that tip of the tongue it's really a universal phenomenon. As we age, we notice it more, certainly with lots of different illnesses. We notice that we can't come up with the right word as fluently as we want to. We can't remember that actor's name. We can't think of the word we want. It can be frustrating, but on the other side, because it is such a universal experience, I find that people generally tend to help one another out when you're having that, oh, what is it kind of moment. Some strategies that you can employ are to, give yourself a moment to pause and stop and think and see if that word percolates to the top. You can describe the word you're looking for, cue the listener in. This is what it looks like, or this is what it's used for. This is where you find it, or it's one of these, talk about the category that the item belongs to. You make associations. It's not exactly X, but it's sort of like it. Find another word with a similar meaning, or even go through the alphabet is something that my patients will do quite frequently until they sort of hit on, yep, it starts with this letter and now it comes to you. And of course, sort of just gesturing and doing whatever you can to help the listener get a sense of what you're trying to get across. More broadly, I always tell folks to decrease your multitasking. The fact is, when we're young, it feels like we're going back and forth and doing multiple things at one time. It's not the case. When we're young, our brains just switch really, really fast. and it feels like we're doing many things at once as we age, and certainly in the face of any illness that can compromise our brain functioning, that sort of falls by the wayside. And so we're not multitasking, we're toggling, and we lose efficiency as we switch back and forth. So what we want to do is do one task at a time, pick a task, get that done before we move on. If we need to make a list of the tasks that we're going to do, that's great. Or even the steps within that, so that we stay on task. And life is challenging, I appreciate it. And we don't always have the luxury of doing one thing at a time. But, if we've got a list of things to do, we can check off. And then if we get interrupted, we know exactly where we were when we get back to our task. So it can be really helpful. We want to make sure that we're working in an optimal environment. And so for most of us, that means getting our materials together, but turning off the email alarms and the Facebook or social media alarms, really making sure that you're in sort of a quiet space where you have the time that you need to work on the task at hand, and then give yourself plenty of breaks, and appreciate that you may not be as cognitively efficient. You might not get things done as quickly as you used to. You might need some extra time at the tail end to check your work, and that's okay. But planning ahead can be really helpful so that you're not finding yourself really stuck in a lurch and in a time crunch. Broadly, I have lots of patients who ask, how can I keep my brain healthy as I age? What can I be doing to help prevent any future cognitive difficulties? And the good news is that there's not one magic activity or thing that you need to do in order to maintain your brain health. So if you don't love crossword puzzles, you don't have to feel guilty about not doing them, because there really isn't a magic tool. What the research really shows is that being engaged in life and doing things that are novel, they're new to you, they're a bit challenging, they cause you to be engaged rather than sort of sitting back and watching television or not sort of actively participating. The more you're doing things that keep you on your toes, like ballroom dancing has a lot of really good data behind it, because it's a physical activity, which is good for our brain, but it's also social. So you're having to read your partner, you're having to interact and judge what's going to come next. And so, things like that, taking a class or just playing card games, going to interesting locations and having conversations with friends, but being engaged in life. Those are the types of things that help keep people's brains healthy. It doesn't need to be learning a new language or anything really, really challenging, but sort of at that edge where it keeps you engaged. Right. So just in terms of these cognitive interventions, I want to touch base on sort of where we know the data say that there's evidence that this helps, and where the data is really lacking. And so we know that the compensatory strategies that I just talked about help cognition, as does cognitive rehab, typically with speech language pathologists. Physical activity tends to be helpful, and it can be really low impact. And then addressing mood and anxiety, as well as addressing sleep. We didn't quite touch on this, but if there's substance abuse, like drinking too much alcohol, too much medical marijuana, which some of our patients are dealing with, getting all of those sort of under control and making sure we're not overdoing it with pain or other medicines that can affect our brain health. All of those have shown to be effective in improving our thinking. Right now, there's inconsistent or lacking evidence for things specifically like puzzles and word searches or Sudoku. There's lots of different brain training games that are available online and for fees. If you like those and you enjoy them and you feel like they keep you sharp, by all means, I'm not going to tell you not to do them. But the data tends to suggest that you get better at the games, but it might not generalize to your everyday life. So what that means is that you get better at these cognitive training games, but it doesn't necessarily translate into remembering things better, recalling where you parked your car, details of conversations, that type of thing. We're not seeing great evidence for psychostimulants. So those are things like Ritalin and other ADHD medicines. And unless somebody has significant memory deficits, some of these dementia medicines that are called acetylcholinesterase inhibitors, things like Aricept, don't tend to be helpful. So for most patients who have had a non-brain tumor type of cancer, these medicines aren't necessarily useful. And then ginkgo biloba, if you are a mouse, there's really great data suggesting that this might help your memory, but unfortunately just doesn't seem to work the same for humans. So just to recap, we know that cognitive changes, fatigue, and mood changes are really common during and following cancer treatment. Not everybody will be affected, but some will. And we know that there are biological as well as psychological and social underpinnings, and that these affect quality of life. And so we want to focus on addressing the things that are within our control, like our mental habits and our health behaviors. And we do have this range of supportive treatments that are available. Other things you can do, I'm a neuropsychologist. I see patients with cognitive difficulties in the context of their cancer and survivorship pretty regularly. And so in some instances where patients are really struggling, coming in and seeing someone like myself so that we can identify what your strengths and weaknesses are, help create these customized compensatory strategies, and identify what other contributors might be causing some cognitive difficulty in your life, and making sure that you're getting in with the providers that you might need to. Quite often I see folks who have sleep apnea that was never appreciated, and we're helping them get that addressed, and that helps clear their cognition and things like that. And then cognitive rehab through what we call SLP, speech language pathology, is often really helpful as well. And so I think, we're at about 4:35, 4:36. So I will end my talk here. And I'm happy to take any questions that folks have.
Tracy, I'm Stephanie Greenberg. I heard you first speak about, well, first of all, I want to thank you for, probably on behalf of all patients listening in or everyone, that Chemobrain was something that is a real thing. And can you help us understand? I mean, I think patients have understood that something's going on and maybe was scientifically, maybe during your long, beautiful, wonderful career, was not sort of recognized as being, a somewhat of a diagnosis. Can you explain how, thankfully, we'll call it Chemobrain, is actually been recognized as legitimate concern and not someone's imagination, because that happens a lot in medicine where patients really aren't heard. So can you explain how Chemobrain is now accepted as a real thing?
Yeah, it's been a real story, and it started primarily with women with breast cancer saying something's not right. I'm off my game. I'm struggling. And for a long time, you're right, it was dismissed as, well, I won't use it, just anxious or depressed. No, those aren't just, those are brain functions in and of themselves. But I think what really shifted is when we started getting more modern neuroimaging techniques, and we're able to say, oh yeah, we can see that. We can see it on the brain scan. We can see that there is a change in the size of various brain regions, and that they track along with how patients are doing on these paper and pencil tests of different thinking skills. And as that neuroimaging has evolved, we have other ways of looking at how the brain uses not just the size of different areas, but how the brain uses energy and how that shifts over the course of disease and treatment. And it's fascinating. I didn't show it in this study or in this slide deck, but there's a really interesting study of twins who had identical twins, one of whom had breast cancer. And they gave them paper and pencil tests, and they actually scored the same. There wasn't a big difference on that. And I think that there's an issue with, are we sensitive enough in our paper and pencil test to really get at what patients are telling us? But then they put them in a brain scan or a brain MRI and had them do an increasingly challenging cognitive task. And as the task got harder, the patient who had gone through chemotherapy, you see that she's just using a lot more brain power. It's a lot more energy being used to perform normally and to do as well as her unaffected twin sister. So they produce the same score again, but you just see in the scanner that she's using a lot more fuel to get there. And if you think about doing that day in and day out over, a long period of time, of course, there are going to be things that fall through the cracks and periods of time when your efficiency just drops and it turns into an error in your everyday life, and you've forgotten a meeting or you've forgotten a detail or you're really struggling to come up with words. So I think there's a bit of a disconnect between our sort of classic tools to see how your brain is functioning and also what we're seeing in the scanner. But it is something that we are truly appreciating as a real phenomenon associated with cancer and its treatment. And what we do is we're, in terms of addressing it, is working on all the things that I talked about that are modifiable, that are things that are within our control, because we find that those, along with just time and the natural recovery process, those tend to help.
Wow.
So we have a question from Pat Kasdan. Are specific changes seen with specific chemo drugs or tamoxifen?
It's a really great question, and one that I get asked quite frequently. And it's a really challenging one to answer because folks end up on different doses of different combinations of medications for different periods of time. And so it's really hard to get very clear comparison groups. But what we do tend to see is that some, particularly when you add in the hormonal therapies like tamoxifen, that some folks do tend to be affected and they have more cognitive difficulties while they're taking those medicines. There's a subset also that just doesn't seem to be affected. Not everyone has that same experience, which makes it a bit more challenging as well. But we do have data suggesting that more intensive, higher dose chemotherapies, taking those for longer periods of time, that those tend to be associated with greater cognitive issues.
Is there any evidence that frank neurodegenerative diseases are increased in patients who've received chemotherapy?
It's a really good question, because everyone is worried, well, if I took a bit of a dip with my cancer and its treatment, is that putting me closer to sort of a degenerative dementia as it's kicking off a process? And what we know actually from these very large epidemiologic studies, looking at medical records for tens of thousands of people, is actually it tends to be the case that we see that having had cancer might be associated with reduced likelihood of developing Alzheimer's disease at these big population level. So it's, whenever we talk about these studies, it's important to note that we're talking about for the group, but there's always going to be exceptions within that. We don't tend to see that, I hate to call it a protective effect, but that possible sort of protective effect for things like vascular dementia, which is a type of brain disorder that's associated with things like high blood pressure, diabetes, obesity, untreated sleep apnea. So anything that's bad for your heart vessels is also bad for your brain blood vessels. And we're not seeing that association there, but there may be at these larger population levels less likelihood of Alzheimer's disease, which I think is really interesting because you can think about the mechanistic possibilities that on the one hand, Alzheimer's disease is a dying off of cells, and on the other hand, cancer is a proliferation and a growth of cells, and there may be some mechanism that we're not quite aware of yet that really link those two processes that are on different ends of a continuum.
I have a question for you. So the bladder cancer journey is unfortunately for our patients is a really long one, assuming it starts with early disease. There's a lot of interventions, there's a lot of cystoscopies, there's a lot of anesthesia, there's a lot of surgeries, there's a lot of treatments, and then it kind of can progress depending on the disease to, serious anesthesia and big surgeries and repeat chemotherapies. So can you help us understand the role, and I have a second half to this question, the role of anesthesia in all this? And also, is there the end part of the question is immunotherapy is now widely used in treating bladder cancer, which has been incredibly positive. Is there any evidence that immunotherapies also create brain fog or what immunofog or whatever we want to call it.
What, don't I wish I had the answer to that? I think, the way the research tends to work is that, new treatments are developed, and then sort of the cognition falls under the quality of life umbrella, which is something that tends to be a secondary outcome, sort of an afterthought in studies, once they figure out the right dosing and how everything works. And sometimes we have to really fight to get those variables tested in these clinical trials. It's not something, even though patients say this is really important for our quality of life, it's not something that is included as often as we would like in research studies. And it's certainly the case in bladder cancer that we're not yet there. I think for the immunotherapies just broadly, we're still trying to tease apart how beneficial they are for cognition relative to standard therapies. With respect to anesthesia, it's something that's been looked at in a lot of different populations. We're increasingly aware that for kiddos who have cancer, and quite often will have lots of different surgical procedures and anesthesia procedures just to even do their scans, that's bad for their brain functioning, having that repeated anesthesia. In our older adult populations, we also see that going through a surgery, and whether it's the anesthesia or it's just the stress of something that's sort of full body and systemic, that it can be associated with postoperative delirium. So we often think of delirium as something that we get with urinary tract infections, for example. The metabolic homeostasis, the balance in our body gets off, and it can cause real cognitive difficulties. People can be very confused. They can even see things that aren't there. And what we know is that repeated bouts of delirium and prolonged bouts of delirium can be bad for our brain function, regardless of whether that's in the context of a cancer treatment or any other sort of medical cause. And so we want to do whatever we can to minimize episodes of delirium, particularly in our older adult population, where they're more vulnerable to it. And it tends to that cloudiness tends to hang on longer than might otherwise be appreciated. So their lab values get back to normal and things like this, but they're still off their game.
David, I'm going to keep going unless you interrupt.
Please, go ahead.
So you did mention that it does go away. So after one of our beloved patients, for example, may have a radical cystectomy, which is a really, really big surgery and treatments after and so forth, and they don't feel like themselves, and it may take some time to physically feel well again. They say at least 6 months. Is there sort of a time frame for Chemobrain to subside after, say, a major surgery that you have, that there's evidence that whatever scan you see is different or better after a certain period of time? And what time frame would that be?
Yeah, first thing to note is that we don't have data directly for bladder cancer, right? So we're stuck sort of extrapolating from other cancers, which is unfortunate. But what we do see is that once sort of the major medical treatments have occurred and patients are sort of settling in and they're not having further, sort of insults to their system, that we tend to see a gradual improvement over those first 18 months, plus or minus 6 months. That tends to be where we see the most improvement. And sometimes that improvement is in only the patient's subjective sense that they're feeling better, but we're still seeing some weaknesses on testing. Other times it's the opposite, that the numbers look better on testing, but the patients are still saying, boy, I'm not feeling quite right. And so it is sort of an individualized journey in many respects, but the general trajectory is that folks will start to sort of climb back up as they get further and further out.
Right. Could it be sort of perceived like, as in stroke patients, that there's been damage to the brain and it just needs to heal? Is that a proper analogy?
I think it is. Certainly we see that areas of the brain, they atrophy and then sort of rebound over the course of treatment. And so I think that that's an apt analogy. It may be that the brain doesn't remodel, that the brain remodels in a slightly different way, and that it does, those exact same pathways don't come back. It may be that there's sort of workarounds that have been developed over the course of the treatment, because our brain is more plastic than we previously appreciated. And there's injury to one area, we tend to sort of compensate by strengthening other areas.
Wow. I first heard of you and heard you give a talk about COVID and COVID brain, which I guess is sort of the same thing. Can you comment on what, hopefully COVID is behind us, but what happened for some severe cases of COVID to the brain? That's off topic, but we all are kind of fascinated by that.
We're all in it. We're all in this COVID, world at this point. Yeah, there are a lot of real parallels with our cancer literature that patients are saying, most patients obviously who had COVID had a more mild course, thankfully. But there's a subset of those individuals who are saying, what, I'm still not quite right in terms of my thinking skills. And we're trying to help address those with them so that we can help them feel better. And sometimes we're not seeing it on our testing, our paper and pencil testing, but the compensatory strategies still are helpful. Addressing all these other factors like sleep and mood are helpful as well, and helping patients feel like they're getting back to their old self. Among our more severely ill patients, those who end up in the ICU, who are on a ventilator, we're seeing some persistent cognitive difficulties that are, consistent with what we see for lots of folks who end up in the ICU, in that there's cognitive difficulties across a number of different types of thinking skills, as well as, real anxiety and mood changes that can persist. We see strokes in some patients, and they can be really young patients. I was just talking with a young woman who was in her 30s when she was hospitalized for over a year following a severe case of COVID. So it's another area where at the level of there's so much variability in how ill a patient gets and what particular mechanisms might be contributing to their cognitive difficulties, whether it's more vascular like strokes and weakening of the vessels, whether it's more of an inflammatory process, whether it is an exacerbation of pre-existing tendencies towards worry and low mood, and the inflammation and other issues are sort of pushing that up to the surface. I think that we, ultimately will figure out that there are a lot of different sort of mechanistic pathways, and that you can't consider every COVID person just a COVID patient. We need to sort of put them in the appropriate bin. And I think that's the case, precision medicine is sort of the term that's often used. And I think that's the case for our cancer patients as well, that getting a better sense of the particular causes and treatments and mechanisms for various patients is really going to be helpful in understanding how to help them feel better and function better.
You really emphasized exercise.
Yeah.
And when I had Noah Hahn in my office earlier today, he's a firm believer in vascular injury as a contributor to this. And he wonders how reversible it's been in some of his patients. But overall, I guess some of the strategies that we use to stay healthy in general are probably good at prevention here as well.
Yeah, it really is the truth that there's no magic sort of pill that we're going to pull out. And unfortunately, or fortunately, depending on how we want to look at it, the things that we know are good for us, eating a healthy diet, sleeping well, managing our stress in healthy ways, and getting physical activity. Those are some of the cornerstones for helping maintain our brain health.
And avoiding substance abuse, smoking, alcohol. You mentioned marijuana. Are there data now that marijuana use obviously can contribute to poor cognitive function just directly, but long-term, is there evidence that it causes changes in cognitive function?
We have studies more from adolescents and young adults. Chronic cannabis use is associated, if you follow them over time, if you're really sort of abusing cannabis, with changes in brain structure as well as reductions in overall IQ. It's also the case that the weed now is not the weed of your youth. The active ingredients are much, much higher doses in the marijuana that's sort of sold commercially and sort of off market, we'll say. And so it's a more powerful type of drug. We are starting to see studies out about particularly older adults who are using cannabis more regularly and how that might affect their brain health. And, you know, it's not benign. Certainly while feeling high or intoxicated, you're going to see that, you know, your attention and memory and things are diminished. But over time, the concern is that those might have some effects on cognitive functioning as well. Now, you know, medical cannabis and using that as a way of addressing pain, some patients find that quite helpful, and they're able to use it in a way where they're not feeling that intoxicated effect. And so they're able to sort of thread that needle. And I'm certainly not an opponent of that, because if it's a, you know, a better alternative for many folks relative to sort of traditional medications for pain that carry with it, you know, a risk of addiction and other side effects.
Tracy, I have a question for you. A patient who sort of identifies as having chemobrain and that there's something off and something not quite right, wherever they are in their trajectory of medical care, at what point do you reckon they reach out, and who should they ask for? They may not have the benefit of having you, although I bet every single person is going to be ringing your phone tomorrow. But if you're sort of in another state or in a, you know, a small, you know, affiliated with a small urology practice, you're going through this sort of on your own. At what point do you say, I think this is real and I want to get help? And who would you ask for?
That's a great question. We're, you know, lucky enough to be at this big institution where we've got every sort of expert available to us. And that's not the case for everyone. So, you know, talking to your oncologist, talking to your primary care doctor, and letting them know that you feel like something is amiss. Generally speaking, those sort of in-office cognitive screeners like a mini mental or a MoCA, you'll sometimes hear those talked about. They're not terribly sensitive. They don't pick up on the kinds of problems that our patients are experiencing.
Is that a test, or is that what?
It's a test. Yep. So, you know, the MoCA, MOCA, was made famous by our last president, who noted that he aced it. So most people have heard of it in that context. But most primary care physicians have one of those sort of, you know, screeners in their file cabinet that they use with patients, but they tend not to be as sensitive as and not to pick up on these issues. There are, you know, now that we have tele services, being rural, being remote isn't necessarily a roadblock to getting a neuropsychological assessment. There are laws and regulations that are helping increase access for providers across state lines in which they're not licensed, which is wonderful. And so there are associations like the American Academy of Clinical Neuropsychology. Their website is theaacn.org. And they have a directory of all of the board certified neuropsychologists in the country, and whether they work with adults or pediatric patients. And so that's a great resource because it tells you that this is somebody who really has, you know, the appropriate training to be addressing your question. And within the context of cancer-related cognitive difficulties, the tele service tends to work out pretty well. There are some patient populations where we really, really need to see you in person. But this is one where I think we can do a good job remotely, and it doesn't require you to go to a big city or a major medical center to be seen.
That's fantastic. Great tip. Now I have one more question. I'm embarrassed to ask it, but I'm going to. So every night on the evening news, Prevagen, is that what? Just say yes or no. I'm putting you on the spot.
I have not. Last I had seen the evidence, there weren't good clinical trial data to suggest that it's useful. The issue with testing cognition and testing any kind of medication to see if it helps is that there's what we call practice effects. If I give you this test today and I test you with that same test next week, you're going to get better just because you you just hadn't. And so there, that's something that I'm always keeping an eye out for, because it's easy to present data that would imply that an improvement is due to an intervention between those two testing time points, when in fact it's just practice effects. I've not looked at the specific data for Prevagen in quite some time, so I'll dodge on what their data look like right now, but I'll just say that in general, that's always a caveat and something that I'm keeping in my mind when there are things like that out there that are for profit, because if it really worked and we had really great clinical trial data, we'd all be gobbling it up, and it would become standard of practice.
Right. Well, thank you.
So, Tracy, we've hit the top of the hour. You've given us a lot to think about today. We'd like to incorporate a lot of what you've said into our institute best practices, and hopefully we can have conversations with you about that afterward. But thanks for joining us. Thanks for the presentation, and thanks to all of you for attending. Stay in touch, and we'll be back again next month.
Thank you so much for having me. It was lovely.
Really helpful. Thanks again.
Take care.
Bye-bye.